Good morning, good afternoon, good evening, ladies and gentlemen. This is Dr. Ming-Tai from Taiwan. First, I would like to thank the organization committee to invite me to do this discussion. Today, my topic is about 10-year-old girl who had a repaired tetralogy of Fallot, severe pulmonary regurgitation, and native dilated RVOT. Here is my outline today, including guidelines and their boundaries, and also data of a case. And I will compare transcatheter PVR and the surgical PVR from 5 perspectives. And finally, I will go back to this hypothetical case. Before intervention, we usually ask, what do guidelines suggest in such a scenario? You can see both guidelines seem to suggest PVR for this particular case, but both guidelines are designed for adults, for grown-up patients. So maybe these 2 guidelines are not quite suitable for this unique girl patient. If patients had their PVR at their young age, there may be some benefits in terms of volume remodeling in MRI, exercise tolerance, and the arrhythmia burden. However, there are also drawbacks for young age patients. They may have a higher risk of reintervention or redo PVR after the procedure. So we needed to balance the benefits and the drawbacks for this particular 10-year-old girl. For easier discussion, I pick up a case from my hospital database. By doing so, we may have more information for judgment on her management. She had a total repair of tetralogy of Fallot at her 13 months of age. She received OY pericardial patch and the Gore-Tex monocuspid valve, VSD repair, and the infundibulectomy. Currently, she doesn't have any symptom. She had a grade 2 to-and-fro murmur, and the echocardiography showed no definite PS, but severe pulmonary regurgitation. Here is her chest X-ray, which revealed myocardial, and the EKG showed the typical right bundle branch block pattern. The QRS duration is 140 milliseconds. And her echocardiography showed the typical IRV dilatation, paradoxical motion of interventricular septum, and the severe pulmonary regurgitation. Her MRI again showed the dilated right ventricle, and the pulmonary annulus is about 25 millimeters. Her maximum oxygen consumption is 25 cc per kilo per minute. The left side video, the left side movie, again show you the dilated RA and the RV. And the pulmonary annulus in MRI was 24.6 millimeters. So, okay, this 10-year-old girl may need pulmonary valve replacement, but should we use surgical approach or transcatheter approach? We do have some patients who had pulmonary valve replacement at their young age. Like the movie show you, this is a 12-year-old girl who had a venous P-valve implantation. But the case number is very limited, so we need to do the search for previous studies to help us have a good and better decision making. I will focus on the 5 perspectives, including mortality and the morbidity, MRI parameters, and the percentage of reintervention, and also arrhythmia burden and others. Both approaches actually had a very low mortality rate and a similar percentage of morbidity. Some patients of the transcatheter group may suffer from device dislodge or coronary compression. In the young age group, both approaches had also excellent results. You can see the surgical group had a very excellent low mortality and the morbidity. In terms of MRI, both groups had a similar improvement in volume remodeling and the reduction of pulmonary regurgitation. But transcatheter group may have less residual PS and less recurrent moderate pulmonary regurgitation. In this meta-analysis, which show you that transcatheter group had a significantly lower percentage of recurrent pulmonary regurgitation. How about the young age group? Another group studied 62 patients with pulmonary valve replacement. They focused on the outcome, which was defined as percentage of patients had significant pulmonary regurgitation, pulmonary stenosis, or tricuspid regurgitation. And they found in those patients younger than 17 years old, the surgical approach had more percentage of recurrent pulmonary stenosis or pulmonary regurgitation when the patient had their last visit. About the percentage of re-intervention, this busy slide shows you several studies, show you the results of several studies. Most of them focus on the comparison between MELODY valve and the surgery. And most of them show these two approaches had a similar percentage of re-intervention, except one which showed surgical approach may have a higher percentage of re-intervention. About the EKG parameters, both approaches had a similar effect on the QRS duration changes. However, the transcatheter group had less ventricular arrhythmia burden within 30 days after procedure. But there were no significant difference in the midterm and the long-term periods. As you know, the infective endocarditis is an important issue in the patient who had the transcatheter pulmonary valve implantation. And the meta-analysis demonstrated the transcatheter approach had a significant higher risk of infective endocarditis compared with the surgical group. Here is the timeline in our hospital. My mentor, Professor Wang, he started the percutaneous pulmonary valve implantation with the handmade valve graft since 2015. So far, we had 52 procedures, and only one patient had infective endocarditis. About the hospital stay, the transcatheter group approach had a significantly shorter hospital stay compared with the surgical approach. About cost, both approach, the cost is very similar, but I think the cost depends on the country. The different country may have a different result. So let's go back to the 10-year-old girl. The both approach had a similar percentage of mortality and morbidity, and also similar volume remodeling in MRI. But transcatheter approach had less percentage of patients with recurrent pulmonary stenosis and or pulmonary regurgitation after PVR. And also transcatheter group also had a less ventricular arrhythmia burden within 30 days after a procedure. And also the shorter length of hospitalization compared with the surgical group. But the transcatheter approach do have a little longer, do have a higher risk of infective endocarditis. And about the percentage of re-intervention, so far we only have a melody valve data, which showed the melody valve, the percentage could be similar between melody valve and the surgical approach. So far, it is still unknown for another valve grafts. So, ladies and gentlemen, for this unique 10-year-old girl, if she does need pulmonary valve replacement, and if RVOT morphology is acceptable, I would recommend the transcatheter pulmonary valve replacement for this 10-year-old girl. Thank you for your attention and welcome for your comments and questions.